Hey, welcome to Life After Nursing School. I'm your host, Caroline Dana, aka Nurse Coach Caroline, and I'm here to help you, the new nurse, thrive in your career. As a former nurse recruiter, nurse manager, and now your personal new nurse career coach, I'm obsessed with making sure you don't just survive your first couple of years at the bedside. I want you to absolutely rock them. From the challenges to the triumphs, I'll be right here with you, giving you the real-world advice and support that you need to shine. Whether you're in nursing school getting ready for life after, or you're already out there in nurse life feeling overwhelmed or even questioning your confidence, I've got your back. I'll be sharing tips, tricks, resources, and strategies that are just for you. We'll dive into everything from landing that dream nursing job to slaying imposter syndrome, and most importantly, how to keep that spark alive and stay the vibrant and amazing nurse that you are. So if you're ready to tackle the things nursing school did not cover, like how to build a career, trust yourself, and keep your passion strong, then get comfortable because we are about to dive in and make nurse life the best life. Today's guest is someone who's become a go-to voice in the nursing world, especially if you've ever felt nervous about responding to a patient in crisis. I'm talking about the incredible Sarah Lorenzini, also known as the Rapid Response RN on social media. Sarah is a rapid response nurse with over 20 years of experience in critical care and emergency nursing. She's worked in the ER, the CVICU, and even formed the rapid response team at her hospital. But what really sets her apart is her passion for teaching. You might know her as the host of the Rapid Response RN podcast, where she breaks down high-stake clinical scenarios and makes complex topics like patho and pharmacology easy to understand. Her storytelling style is super engaging and packed with real-world insights that help nurses build confidence when it matters most. She's also the creator of the Rapid Response Academy, which is all about helping nurses sharpen their assessment and critical thinking skills in order to handle emergencies like a pro. Sarah's mission is simple but powerful. She wants every nurse to feel prepared, empowered, and ready to save lives. I'm so excited to have her on the show today. Let's get into it. Okay, Sarah, welcome to the Life After Nursing School podcast. We're so excited to have you.
Thank you. I'm happy to be here.
I'm really excited. I have a long list of questions to ask you, so I don't want to take a moment to sit and chit chat. I want to dive right in. Can you start by just telling us a little bit about you and your career? I would really love to know how you ended up as the Rapid Response RN on social media and also as this leader in rapid response or emergency kind of side of nursing.
Sure. Well, I definitely did not go to nursing school thinking I would be a podcast host. That was not even a thing in 2000 whenever I started the nursing process. And I also thought I would be a labor and delivery nurse, and I've never actually worked in labor and delivery. But so in nursing school, I applied to labor and delivery as a CNA. They would not hire me, probably because I was 18 years old and had never worked in a hospital, knew nothing. But the ER, they took me in. So I got a job as an ER nurse tech in nursing school. Best thing I ever did because I learned so much seeing real clinical scenarios like outside of the textbook, like seeing it come to life with patients in front of me. Best experience. And I actually fell in love with taking care of patients in crisis. I never saw myself as like an adrenaline junkie. I still am not an adrenaline junkie at all. I wasn't your typical ER nurse, like rough around the edges and like jumping out of, I don't know, airplanes and skydiving and like all these like high risk behaviors. This is not me at all. But I fell in love with the opportunity to take care of people like on the worst day of their life and to be with them and walk them through that high stress experience. I found that I'm really good in those types of chaotic environments to kind of bring calm to the chaos. And so surprising myself, but everyone that knew me, I became an ER nurse right out of nursing school. Okay, so that was in 2004. I graduated nursing school at the ripe old age of 19. I was an ER nurse. All my friends were like working at the mall and I'm like night shift in the emergency room on Friday night. Anyways, loved ER nursing. It was such a good fit for the way God wired me and did that for like 8 years. Discovered that I liked teaching nursing as much as I like actually doing the nursing role. And so went back to school for a master's degree. In grad school, all my professors were like, you need to do something outside of ER to like expand your horizons, your understanding of healthcare. I was like, okay. So I went and worked CVICU for a while. Then I was asked to be on the rapid response team at the hospital I worked at the time. So ER, CVICU, rapid response, finally finished that darn master's degree. I worked as a nursing professor for a whopping 1 year. And while I loved the students, I wasn't quite ready for like academia life, like faculty meetings and all that stuff. And then the nurse who was the charge nurse when I was a new grad ended up being the director of the ER and reached out to me, asked me to come be the ER nurse educator now that I had my fancy master's degree. So I went back to the ER that I started in as now the educator. Loved the educator role. It was like a great mix of being at the bedside and also training other nurses. It was a good schedule for being a mom. And then COVID hit. And while everyone was like, get me away from the bedside, I was like, no, like I see this disease and I want to be in the trenches fighting this virus with my peers. And so that's when I went to hospital leadership and actually asked to start the dedicated rapid response team at my hospital. That was in August of 2020. So I left my educator role, became the rapid response team supervisor, built the team from the ground up. And I love being a rapid response nurse. It's such a great mix of ER and ICU nursing and nursing education. And there's so much opportunity to teach. But I remember talking to my husband like a couple months in. I was like, man, now I miss being an educator. He's like, no one's stopping you. Just because it doesn't sit on your badge, like you can still be teaching. Like I do teach, but like things are busy. I get pulled away in the middle of trying to explain things to someone. It's hard to really like break down the pathophys when there's like 6 other patients the nurse has to go care for. He's like, why don't you start a podcast? I laughed when he first told me that. But after like a little bit of internet research and a $15 microphone purchase from Amazon, I recorded my first 3 episodes literally in a closet. Like there's like coats and luggage all around me with my microphone and my laptop sitting there. So I recorded episodes. My goal was I want to highlight some of the great saves we've made at our hospital and really take time to like dive into the pathophys and the pharmacology and use the story of this patient that I cared for to kind of break down all those things like a case study. So I thought it would be like a service to the nurses I worked alongside. Like, hey, remember that case we had in 235? I made a podcast about it. You know, it's educational. Check it out. Not realizing there's nurses across the globe that also want this kind of content. And so it very quickly blew up. And I was like, okay, I guess I got to make more episodes. But it was such a great opportunity to share my heart for nursing, not just like the nerdy sciencey stuff. I love that, but also like the heart of nursing and the important role that nurses play, both in emergencies, but also just like in the healthcare system as a whole, you know, advocating for patients alongside family members, like all of that. I wanted to teach that stuff too. That was the birth of the Rapid Response RN podcast, where I teach basically the pathophys, the pharmacology, and the heart of nursing in podcast format. That was a very long-winded answer to your short question, but hopefully it answered your question.
It answered my questions, and I actually took some notes, okay? First of all, I knew I liked you because I'm also an ER nurse. So there is something, you know, I don't know if we have like a loose screw somewhere or something.
Yeah, probably, just a little bit.
There is a particular person that I feel like ends up in the ER. What I loved about your story and can resonate with is that I thought I was going to be an ICU nurse, and I had no desire to be ER, and it sounds like you at the same, but with L&D. And I've never worked in ICU as of this moment. And, you know, you haven't in L&D. So it's nice to see that we may come into this field thinking that we have it figured out and we know what we want, but life takes us in another direction. And I mean, so cool to hear your story unfold. I also have 2 questions for you. The first being, was it really weird going from the ER to the ICU?
Absolutely. Like a fish out of water. Yeah. So in the ER, you get really good at rapid assessment, rapid decisions, like boom, next.
Yes. Move on.
The ICU is not the place for that. ICU, you had to tap into my like, okay, data analyst, big picture, deep dive into the labs, into the pharmacology, the pathophysiology. There's more numbers I'm keeping track of than ever. Not just basic vital signs. Now there's like SVR and SVV and cardiac index and like so many more numbers that I had to know about. It's very different. ICU nursing versus ER nursing. The personalities that are drawn to each one are very different. But I can kind of vibe with both, honestly. I have this side of me that's like very fast paced, like next. I can make decisions very quickly. I can fly by the seat of my pants, but I also really like deep diving into stuff and understanding things thoroughly. So one thing I loved about the ER is that I had the opportunity for so much like diversity in patient care. My day was different every single time. Like I liked the challenge of like something new all the time. What I didn't like is I feel like I never was caught up. I never fully understood every detail about my patient. I didn't have time to even go back and see what their potassium result was because it was next patient. They're off to med surg. They're off to the next floor and I get the new one to fill in the room. So the opportunity to deep dive was challenging, but in the ICU, what I loved is you have the same 2 patients for maybe days, maybe weeks, So you really get to know all the background of their diagnoses, their surgery, their family, like their lab values. So I really got to deep dive. So if you have a great patient, that's awesome. If you have a challenging patient, that means you got several days of this particular challenge of this patient. There are several times where I was like, all right, I fixed them. They're stabilized. I recover the next one. They're like, oh no, Sarah, like this is your patient. The rest of this shift and probably tomorrow when you come back. I was like, okay, all right. So I had to like find things to keep myself not entertained, but like busy, basically. So my locker had, I don't know, like a bunch of different body washes and like nice razors and like late shampoo and nice brushes. And I would just take time to like really dote on these patients because I already fixed them. Like the blood pressure's good, the heart rate's good. So now we're gonna shave your face because your family said you're always clean shaven. And now that you're intubated, no one shaved you. We're gonna shave your face today. I really enjoyed the opportunity to like get to know patients really well, get to know the whole story. So again, I can go both ways, but let me tell you, the people I worked alongside was very different personalities, ER personalities versus ICU personalities.
I think that says a lot to your level of resilience and adaptability to be able to kind of go from one side of things to the next. And I agree with you. When I was in the ER, we would do all these things to like stabilize the patient, fix them for the moment, but then we never got to see like how did that intervention affect the patient later down the road? Did they get better? Did they end up passing away? Like what happened to those patients? So I do think that is really nice that you got to see sort of the flip side. My other question for you is that you started the RT team at your hospital.
I did. So
Made
there's two big hospitals in my area. The biggest hospital is like 1,500 beds. They've had a dedicated team since like 2005, like forever. So I worked on that team.
Okay.
And then when I came back to the hospital that I had started as a new grad, they're at like a 550 bed hospital, still a pretty good sized hospital, but not quite as big. Yeah. They didn't have a dedicated team. So they had a process. If a rapid response was called, the ICU charge would leave the ICU, come to the bedside of the patient who's crashing, stabilize the patient, figure out the next plan of action, whatever. So they had a process. But as you can imagine, when COVID hit, that process was not quite cutting it because now the ICU is sicker than ever. The med-surg floors are sicker than ever. Staffing was way thinner than we're used to because so many nurses had left to go travel. So which is not a good thing to have the primary charge nurse from the ICU constantly pulled to more rapids than they're used to even responding to. So the ask to admin was like, can we please have a dedicated nurse who that's all they do is not just respond to emergencies, but also help to prevent them. How many of these patients can we prevent from needing intubation if we were more proactive in their care? So yes, they said yes. They gave me 1 FTE, which was mine. And they said, if you can prove your efficacy, we'll give you more. And so long story short, now we have a team of 10. So we have built the team since then. We're also a Beacon awarded rapid response team. So we've worked really hard to like prove ourselves, to make an impact in the hospital and to maintain that level of excellence throughout the facility, shifting the culture, improving patient outcomes, all the things. So yes, I started the team in 2020 and now it's 2025 and we're still going strong.
That's amazing. Honestly, I can't imagine, especially being a new nurse and not having those resources available if your patient were to decline, So I think the fact that you identified that need there probably made such an impact and maybe more than staff even realized because they were lucky to have someone like you to kind of step in and fill in that gap. So that's incredible. I literally have chills. Is this hospital a magnet hospital?
The bigger one that I worked for, yes. The one that I work for now is not.
Okay. Because I just feel like that is like some magnet stuff right there of someone kind of coming forward and starting this team. Okay. Now, I have a wide range of experience from a nursing standpoint of listeners that listen to this show. So would you just take a moment? I know we jumped in. Would you take a moment to explain what an RRT is and maybe some of the roles that typically respond to code situations in an inpatient hospital setting?
So just to define terms, every hospital has a different name for their rapid response team. It might be called like the medical response team or like critical care outreach team, or I've heard PIT team, SWAT team, STAT team. Like there's so many different terms. All meaning the same thing is there is an emergency happening. If we were outside of the hospital, we'd call 911, but we don't call for an ambulance on the inpatient side. We call a rapid response or whatever your hospital calls activation. Joint Commission doesn't tell us who has to be on the team. They just say every hospital has to have some sort of process. And so that looks different for every hospital. Again, my hospital now, it's going to be a rapid response nurse. So a dedicated nurse who just does that all day. Some hospitals it might be maybe an ICU charge, the ER charge, someone is going to respond, house supervisor, a physician or some sort of provider has responded as well. Respiratory therapy, I think phlebotomy comes to our rapids. Every hospital is different, but there has to be some sort of process where when a patient's crashing, it's not just the responsibility of the one primary nurse to manage this crossing patient. It is all hands on deck. We're all working together to intervene for the patient and also to get to a diagnosis as to why this patient's having this decline. And then we have to decide as a team, that interdisciplinary team of respiratory therapy, nursing, physician, whatever, what to do with the patient from here. Can we stabilize them to stay on the med surg floor? Or do we need to move them to a higher level of care? Or do they have to go to the operating room or the cath lab or, transfer to the hospital? What is the plan for this patient from here? So that is the role of the rapid response nurse. Again, that role looks a little different in every facility. One thing that's unique about ours is that we're not only responding, we also really like to prevent emergencies. So there's many things that we do proactively to help catch those patients early on before it turns into a full rapid response. There's different scoring systems that hospitals might use. We'll round on patients. We have this thing in our hospital called a nurse consult, which is where if the nurse is like, something's up with my patient, vital signs are okay, I don't know what it is, but something's happening. Maybe it's intuition, maybe it's just they've noticed a decline in their mental status and the way their eyes are, their breathing, whatever. So nurses can call us and say, hey, I don't need the whole rapid response team. I don't need a doctor to come or like the phlebotomist. I want another nurse to lay out, a nurse who's very experienced that can come help me figure out, do I need to be like advocating harder here? How can I optimize this patient? How can we work together? So we show up as just like physicians consult specialists, like they want the cardiologist to weigh in on their patient's case. Nurses have a specialist, which is a critical care nurse that can come weigh on the case and help bedside nurse, Sherlock Holmes the chart a little bit, maybe help to advocate. I've got some big shoulders. I can put my foot down if I need to and support a new nurse who's feeling maybe intimidated by the provider. So we are there for those proactive things too. And I'll tell you, having a team that's doing not just reactive nursing, but proactive, we have seen the amount of code blues in our hospital cut in.
Wow.
So I think that's a testament to not just that we exist, but more that nursing intuition is worth listening to. And I think because we're there, nurses are given a voice. They're more empowered to speak up and advocate. And we're catching those patients before they turn into a code blue and preventing it altogether. So yes, rapid response teams save lives as a team.
Absolutely. And I do think that's a good piece of advice for listeners to take away, especially if you're a new nurse, is once you start working, get to know these resources that you have. I know in the hospital that I first started to work at, they had CRNs, which were clinical resource nurses. Sounds kind of like your nurse consult sort of process, where CRN would come to the codes or RRT. They were ACLS trained. And also you could call them at any point in time if you're confused on an order, if you have a heparin drip that you have to recalibrate, if you just don't feel good about a patient. And they have so much expertise, that's part of their job requirements. And they come with sort of that seasoned experience in addition to really help whoever it is taking care of the patient, whether they have either a new nurse or maybe they're experienced, but they just don't know what's going on. And it's sort of like two heads are better than one. And like you said, usually the people in these roles have found their nursing voice. They know how to advocate. They know some of the workarounds to get things done for patients, and it makes a huge difference. So if you're listening and you're a new nurse, definitely figure out if your hospital has some kind of point person, a clinical resource nurse or a nurse consult process or something that you can lean on if you feel like you need another set of eyes or some expertise at the bedside with you.
Yeah. Can I just add one more thing to what you had said? When I first started the rapid response role at my hospital, I noticed a lot of nurses being like, I'm so sorry I had to call a rapid. So sorry about that. And I had to be like, no, we're not saying sorry. In fact, you get a high five for calling a rapid. The fact that you had to call a rapid is not a sign that you did something wrong or that you were missed something. I'd say on the flip side, it's a sign that you are utilizing your resources and recognizing patients who are declining early and speaking up and advocating. These are high five worthy things, not things you apologize for. So no, apology not accepted. High five instead. So I just want to throw that out there. If you feel like, oh, I hate to bother them. I had to call a rapid again today. Oh my gosh, I'm terrible. No, you're freaking awesome. You're recognizing and you're speaking up. Keep going. Yeah, that's all. Continue.
No, I love that you bring that up because I know even back when I was a new nurse, I remember being like, do I call one? Do I not? I don't know. And you kind of go back and forth and you're like, I don't want to cry wolf or I don't want everybody to come running and then be like, oh, geez, a new nurse. This is something so simple. But I have never regretted an RRT if I've called. There have been times where I've regretted waiting too long, So I feel like in a safety culture hospital, really, we should be commended and encouraged to call an RRT. We'd rather be safe than sorry. And it is really funny because recently, actually last semester with my nursing students, we were on a med surg floor and this patient was on Lovenox and he started to cough up blood And we were kind of like, is he coughing up? Is he throwing up? What's happening? He was alert oriented and it was getting worse and worse and worse. And it was to the point where like his airway was somewhat compromised. Like he had just a lot coming out. And I said to the doctor, actually was on the floor and came in, and I was like, and I'm the instructor, so I don't work there. And I was like, why don't we just call an RT? And they're like, oh, I don't know. I'm already in contact with ICU. I don't think we need to call that. I'm like, okay. I'll be at the bedside taking care of the patient. It's hard when I didn't really have so much skin in the game. And I was like, I think this is actually a nosebleed, which sounds crazy because it was actually coming out of the mouth, but I think it was, in the back of the throat, but actually more, because I've seen some really bad nosebleeds. Okay. So it gets worse. The doctor comes in and says, you're right. We need to call an RT. So I'm like, okay, beautiful. So they call an RT. Everybody comes up. They pull out a ginormous blood clot, huge blood clot that I think was just dangling in the poor man's airway, ended up rushing him to the OR, and he had unstable nosebleed, which is like, it happened so quickly. My students were like, wow, that was awesome. I know that sounds terrible to say, but they were excited to have seen all that. But I also used that as a experience to say, guys, you're not wrong if you call an RT. If something doesn't seem right, if something's getting worse and you feel like you're not getting answers from the ICU, or you page a doctor and you're not hearing back, or they're not really trusting your judgment, or maybe they're not as concerned as you, but you feel in your core something's going on, you call the RT, so it was a really great learning lesson. And it was so cute because after the doctor came up to me and she said, you were right. We should have called earlier. Thank you so much for suggesting it. And I guess she's a newer doctor, but it all worked out. Patient's fine now, but it was a really great and unique RT learning experience.
For sure.
Now, I want to ask this question. It might be a little too broad, but what are some early warning signs that maybe a patient is decompensating, and how can new nurses potentially catch these signs?
Sure. So the warning signs will be different for different pathologies, right? But
Yep.
I think some of the big indicators that maybe aren't stressed like they should be are skin, worker breathing, and mental status. So we often are like, what's the blood pressure? What's the blood pressure? If the blood pressure's fine, patient's fine. Not true. I can't stress that enough. Patients will compensate and compensate, and then they have reached their limit. They are done compensating. We want to catch the patient before they fall off the edge, right? And so if you think about it, if the body is recognizing something's wrong, it's going to compensate initially by shunting blood to the core. So pull back the covers. Look at your patient's skin. Are they cold? Are they clammy? That should be big red flags. Additionally, mental status. So we're trying to get flow north, right, to the brain. And so if the patient's not getting what they need, they're going to have altered mental status. And sometimes that alteration is now they're agitated, confused, pulling at things and they weren't yesterday. And sometimes the alteration is, okay, now they're sleepy, lethargic, can't wake them up. Either end of the spectrum, it's an alteration from baseline. And we should be very concerned about that. So I'll often get a call like, the patient's blood pressure is 60/40. I'm like, oh, okay. How are they acting? Oh, they're fine. They're talking to me. Great. So I'm not running. I'm walking because the patient is getting perfusion north. But if the nurse says, yeah, I can't wake them up. Oh, shoot. I'm running. That patient's very sick, right? Even times the blood pressure has been fine, but the mental status has changed like acutely. Very concerned. That tells you something serious is going on. And the other one's worker breathing. And this is the one, girl, people don't actually count the respiratory rate. Everybody put 16, and then we miss so many patients. So like in our hospital, we use Muse to help identify patients early on. It's the modified early warning score. But if everyone's typing in 16 to their respiratory rate and the patient's actually breathing 46 times a minute, I will never know. I will never know the patient's declining because the Muse is going to be a fine score, right? Until the stats finally drop. But the fact that the patient's working so hard should be concerning. And I think a lot of times people are like, oh, well, their stat's still fine. They're statting 91. Okay, look at the patient and not just the number on the monitor. The number on the monitor can make you feel a little better, but if I see someone working so hard to get a whopping 91%, something legit is going on. So for me, it is obviously vital signs, right? Tachycardia, hypotension, those are like, you can't argue with those. Those are easy, right? Call them rapid if they have those. But also, like, if they're working really hard to breathe, if their skin is just like the wrong color, the wrong shade, it's cold to touch, it's clammy, that should be very concerning to you. If the person who was talking to you this morning when med pass is now difficult to wake up, you should be concerned. So when you call a rapid, you don't have to wait until you're like, oh, I figured it out. I know what's wrong. I'm going to call a rapid now. No, you call a rapid when you notice a change. You don't have to have the answers yet. I'm not going to tell you, well, what happened to them? Why did they do this? I don't know yet either. We're collectively doing investigations to figure out the source. So don't wait till it gets to that point that either you figured out or they turn blue. I would say call the rapid response when you notice that the subtle changes. They're breathing a little faster. They're not quite waking up like they used to. Their skin is much cooler than it was. Those are like the more subtle things. Vital signs, obviously, call, but the subtle things are like your clinical assessment. I think that that's the thing that maybe newer nurses get tripped up on is they call the doctor and they say, hey, the patient's declining. And the doctor's like, okay, what's the vital signs? And then you read off perfect vital signs. And the doctor says, oh, they're fine. It's learning how to articulate, yes, but their work of breathing has increased. They're using accessory muscles. They're breathing 40 to 46 breaths a minute. They're fine. Their respiratory rate is fine. But like this morning, they were awake and talking and asking me questions about the med pass, and now I can barely wake them up. They're fine. Their abdomen's fine. We did a chest x-ray this morning or a KB this morning. I know, but now it's very distended and tender to touch. And like using your clinical assessment, be able to verbalize that to the provider is how you get their attention rather than just say like they're declining. Okay, you need some data points to like speak the same language as the physician. Even as the rapid responders, I'll get that call and I'm like, I need more information to figure out how stable this patient is. So when nurses can articulate that, it helps a lot. If you can't articulate it, fine. Still use your voice, wave your hands in the air, something. But I think learning that language of describing your assessment findings, I think is very valuable in your advocacy efforts.
Yeah, definitely. It's like painting that clinical picture for people. And like you said, patients can compensate for quite some time and then it's too late. And I think what's so important to know too, this goes with really any issue going on with the patient, but I know for sure with things like stroke, cardiac event, sepsis, like early recognition is crucial for the outcome of patient. So the earlier we can notice a change, even if it's something subtle and we're not quite sure, is it a stroke? Is it not a stroke? Is it something else? We don't need to know what it is. We need to know there's a change. We need to arc that up and get the resources at the bedside to help that patient in case it really is something that is truly an emergency.
Absolutely. And as far as stroke goes, I would say over half the stroke alerts I go to are not strokes. And that's fine. The patient had a legit alteration of mental status. They were weaker on the one side. Their speech had changed. Oh yeah, we're going to CAT scan that all the way. Thank goodness it's not a stroke, but sometimes we don't know till after the fact, right? I don't have CAT scan vision, neither do you. So if you see stroke-like symptoms, activate the team. We'll let CAT scan sort that out, but no need to be like, well, let's wait and see if it gets worse. Well, what if worse means they lose their airway, right? What if worse means now that worse can come really fast. So let's not wait. Let's just get the team coming. We can always cancel it later. I always say call early, call often. I would rather show up and it not be an emergency than wait until it's a legit emergency and now it's too late to get intervention for this patient, especially with stroke, right? Because you have a narrow window with which to give the thrombolytic. So
absolutely. Now, let's say a new nurse walks into their patient's room and they notice their patient is getting worse in some way. What would you suggest their first move then and there? If they notice, wait a minute, my patient's, not making sense anymore. And an hour ago, he seemed alert and oriented. What do you think what do you recommend their first move then and there to do?
Okay, so for the change in mental status thing, I think I would get another person in the room, call for someone to bring you like a glucometer. Let's rule that out.
Yeah.
Take a set of vital signs. What are the things that can cause alteration of mental status? Blood sugar, hypotension, hypoxia. Let's rule those things out real quick. Honestly, you don't even have to do that. You can go ahead and call a rapid and cancel it if you find out, oh yeah, the blood sugar was just 30. We gave him some sugar and he's better. Yeah. Oh yeah, the oxygen was turned off. Oops, turn it back on again. We're good now. Like if you can fix it and cancel the rapid, great. But I would rather you get us coming. It's going to take me 2 minutes to get to you from the other side of the hospital. Go to call a rapid. So call a rapid and then start kind of narrowing down like what could it be? And I think for almost every diagnosis, getting a blood sugar and a new set of vital signs is probably a good first step.
Absolutely. Absolutely.
And then obviously ABCs are king, right? Are they awake and maintaining their airway? How is their work of breathing? Do I need to support that in some way? Do I need to add more oxygen to them? Do I need to breathe for them because I'm not taking enough breaths, period? And then obviously circulation, like do they have a pulse? But again, that's like more extreme. I think what you're asking is more for like the rapid response type situations, not so much the code blue ones.
So it is sounding like if you're noticing your patient declining, it is safe to then call an RT, but then also start gathering some assessments on your own, gather some information. So when the people show up in the room, you can say, we just grabbed a glucose, blood sugar. This is what it is. These are the latest vitals. I just did a neuro assessment. This is how it's going. These are the changes that I'm noting, and having that information readily available for the team, because then we can obviously jump in and get going. And I think that's really, really important. Now, in your opinion, what are a few critical skills or nursing practices that every new nurse should master to feel more prepared for emergency or code-like situations?
Okay. So I think that we all are taught these things, but then often nurses freeze in the moment because this is not the environment that I trained in. You know, like we all take BLS, we passed on the mannequin, we know how to, bag the mannequin. Okay, good, we're checked off. But like it's different in B space in the corner of the room. Where is the bag valve mask? Like where is the oxygen hookup? Where's the crash cart? What does each drawer of the crash cart have? How do I use this defibrillator? I'll use the AED and BLS class. How do I use this one? So my recommendation is you need to get familiar with where things are located and how resuscitation is going to look in every area of your department. So like just take a mental note, where are the crash carts located? Where are the wall hookups for oxygen? How do I kick this bed into neutral to move it away from the wall so I can get behind the patient and actually bag them effectively? How do I use this defibrillator? This is different than one I trained on in BLS 2 years ago, right? What do all these drawers in the crash cart contain? And as your charge nurse probably checks the crash cart every shift. So I would say, ask your charge nurse, can I go with you when you check the crash cart today? You can kind of just remind me where things are located. If I need to swim in a race, let's say, I could study all I wanted how to move my arms and how to swim. But if I'd never actually swam and I didn't know this particular course, or I would just be floundering in the water. And so there is value in actually putting your hands on the equipment, making mental checks of what I would do if I walked in and found my patient unresponsive, what would I do? The other thing I like to remind new nurses is you're not responsible for all of it. Saving lives is a team sport. So here is my recommendation. I like to teach the rescuer 1, 2, 3 model.
Okay.
So if you show up and you are the first rescuer, your job as the first rescuer is to recognize the patient is pulseless, call a code blue, pull the lever, press the button, yell at the top of your lungs, whatever, get the team coming and hop on that chest. You're doing compressions. That's all you're doing. There's more to be done, but you are one person with 2 hands and compressions is the most important thing right now. So hop on that chest. Someone else runs in. Oh, looks like I'm the second responder. Okay, if you are the second responder, your job's airway. So go ahead and get that BVM, attach it to the wall at 15 liters and start bagging the patient. I see a lot of people awkwardly sideways bagging. No, put the bed in neutral, push it away from the wall, come behind the patient, over top of them, get a good seal on the mask, and then bag. So rescuer number 1, compressions only. Rescuer number 2, bag in the patient. If you run in, you find yourself being the third person, well, your job is to get the pads on the patient. So get that crash cart in there, put the pads on appropriately, attach it to the defibrillator, see if we should shock this patient. Most crash carts have a backboard you can put underneath the patient. So roll the patient, put the backboard underneath them to give a better quality compressions. And by that time, the first responder is probably tired doing compressions, swap out. So if you're the third responder, you're going to get things set up on the defibrillator and swap with the compressor. Those first 3 people are the most important. There are more jobs to be done. Yes, we have medications to give. Yes, we have documentation to do. Yeah, there's more to be done, right? But if we are scrambling to see who's going to document and no one's on the freaking chest, the patient will not recover. So the first 3 are super important. So if you are brand new, just get those first 3 roles down pack in your head. If I show up on the first person, I'm doing this. If I show up on the second person, I'm doing this. On the third person, I'm doing this. If you're the 4th, 5th, 6th, whatever, they'll give you assignments. You may be documenting. You may be giving meds. You may be the runner. There's more things to be done. But those first 3 are literally life-saving.
I love that. That's really helpful guidelines for people. And it actually segues into another question I want to ask you. And that is, what does good teamwork look like during a code to you, and how can maybe a new nurse contribute to that team dynamic? Of course, now they know if they're person 1, 2, or 3, they sort of have an action in place, but say they come in maybe, and they're person 4 or 5, or I don't know, maybe it's their patient, maybe it's not. Do you have any tips on how someone can kind of jump into an already maybe cohesive team and help kind of with the dynamics of that?
Sure. So first I want to say I have a whole podcast about this that's 45 minutes long. It goes into detail for each role and what to know for each role in the code. So I would start there.
I'll link that in the show notes just so everybody
okay, awesome.
After Sarah.
But a short answer is show up and ask, what role can I do? Do you need a runner? Do you need more compressors? What role can I do? And maybe if you're brand new, you can say, I would like to blah, 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 but I'll do whatever's needed, right? Maybe I've never done the blah, blah before, and I want to try this out. If you are brand new, do not volunteer for documentation. That is the hardest job in the code. It's almost written off as oh yeah, you're just the secretary. The documenter has a very difficult job. Do not be the documenter. The other thing too, I think people have this idea of oh my gosh, the patient's dying. It's we're on a battlefield. We have to yell at each other. No, you can still talk in the same tone of voice that you usually talk. You can even still use manners please and thank you. You can even, and this is crazy, you can even give compliments such work, great compressions, great job. We're all these positive things actually do change the vibe of the room. We are not going for battlefield chaos. We are going for smooth, calm, collective, cohesive. Like that's the goal here. And so don't contribute to the chaos with like yelling, screaming, throwing things. Keep the same tone of voice. You don't have to make things worse. Other thing, people, myself included, when we are stressed, tend to talk faster and faster. We start freaking out. That is very unhelpful in a code. So me personally, I've had to make a concerted effort to slow my speech and make sure that I'm fully enunciating everything that I'm saying. And because I'm a female who tends to talk kind of like this because I'm a really happy person, I had to make an extra effort to even lower my tone a little bit. And I call this my code voice, where I actually talk very different in a code. And people that know me well, they're like, they kind of make fun of me a little bit, like, oh, Sarah's talking. No, guys, it's code voice time. Like, and that's fine. I'm fine being made fun of because I know if I talk my normal happy Sarah tone, stuff will get missed, right? The volume of the room is too high. Those like high decibels are not helpful. So I lower my tone. I talk in a deeper voice to make sure everyone in the room can hear what I'm trying to enunciate. In addition, in a code blue, we use this thing called closed loop communication. It is the cheesiest looking thing outside of a code blue. In a code blue, it's life-saving. So what it looks like, can I just practice with you, Caroline, real quick?
Yeah, absolutely.
Okay. So Caroline, can you grab me some more flushes?
Yes, I will grab you some flushes.
Perfect. So she's closing the loop. All right. So she's like, what are we doing right now? Because if I'm just like yelling things out, stuff gets missed. So either I'm like, can somebody get some more flushes? And then either everyone's like, oh my God, I will get flushes. And now I have bundles of flushes I don't need. Or everyone just assumes someone else is taking care of the flushes and I never get them. But if me and Caroline exchange in this cheesy closing loop thing, I say, Caroline, can you grab the flushes? And she says, yes, I'll get the flushes. And then the loop is closed. I know it's taken care of. Everyone else in the room also knows it's taken care of. And it actually gets done. So in a code situation where we're communicating, we close the loop every time, even though it kind of looks cheesy. So if you're new and someone asks you to do something, repeat it back. Yes, I'll hop on the chest for compressions. Yes, I'll hook the suction up. Someone says, hey, can you hook up suction? Yes, I will hook up suction. Don't just nod your head and go do it.
Right.
Close the loop so we all know it's taken care of.
I think it helps too if you can make eye contact, if you can say their name, like Sarah said, Caroline, and even if I took it a step further and said, yes, Sarah, I will go grab you some flushes. Like it is clearly like A, B kind of conversation. And that is like almost a checklist. Everybody knows that's being done. Love that you brought up closed loop communication. And communication in general, I've been in many codes. I'm sure you have too, Sarah, especially in the ER where everybody floods to the trauma bay. And then someone eventually says, if you're not doing anything, get out of the trauma bay because it's crowded. People are kind of chit-chatting on the side and it's too much, right? We need to eliminate all that extra noise, distraction, people in the way so that we can obviously give the best care possible to the patient that needs it.
Yeah, for sure.
Yeah, that's so true. And team dynamics, when you have a good team running a code, it's like the Olympic team, right? Like when you have Olympics doing the sport versus regular people, they'll look a little different.
For sure.
Now, what would you say if the new nurse calls the code on her patient for whatever reason, and then she just freezes or panics? Do you have any like mindset strategies or any tips to kind of help the nurse like ground herself or himself and, be a little bit more helpful or engaged versus then in that frozen fight or flight mode?
Sure. So I will say, if you find your heart racing, you can't catch your breath, your hands are shaking in a code situation, there's nothing wrong with you. In fact, you are working just fine. That is your sympathetic nervous system doing what it's supposed to do. And it is dumping epinephrine and norepinephrine into your system because it recognizes there is an emergency. And that dump of hormones is to help you flee the scene, fight the bear, whatever the emergency is. Granted, this is not an emergency that you are personally experiencing, but your body doesn't recognize that. It's just like, there is emergency alarm, dump of epinephrine, dump of norepinephrine. It's like, how's that feel? It feels like your heart is racing and your hands are shaking and you can't get your breath. That's what it feels like. And so it's very easy to interpret those sensations as, oh my God, I can't do it. I can't breathe. I can't do this. Oh my God, my hands are shaky. What's wrong? I can't do this. Oh my God, I can't catch my breath. My heart's like, all these things make us think that we're inhibited in some way. On the contrary, all that stuff is to help you care for this patient, right? You are going to be stronger than you've ever been before when you have this dump of epinephrine surging through your veins. You're going to be faster. You're going to be sharper. Like you will have more endurance to do that full 2 minutes of CPR to get that patient up off the ground. These things are there to help you. So I think step one is recognize these sensations happening in my body right now are there to help me help my patient. That's thing number one. Thing number two is to just take a second, take a breath, and kind of be aware that what's happening in your body. I think that we get so overwhelmed with all the tasks that need to be done, all the people flooding in the room. Just take a breather. You will function so much better if you take literally 5 seconds to slow your breathing down, to focus so that you can answer questions appropriately. It is something I struggle with too, that whole like freeze response. But for me, I've trained myself over and over again to interpret those sensations like, all right, this is happening. I feel my body is ready for an emergency. My body is responding. And I know I'm trained for this, right? I'm past ACLS. I have studied my butt off. I have, done these scenarios before in simulation. Like I have prepared for this. Now let me put that to practice. And then I would say choose some sort of code word or phrase that's going to tell your body, all right, it's time to kick into gear. It's time to focus. Everyone has a different one. Maybe it's like smooth. Maybe it's calm. Maybe it's focus. Maybe it's whatever. For me, the phrase is it's go time. So like I literally look at my hand shake. I'm like, all right, it's go time. Like this is your time to perform for this patient. And so I just have to mentally make the note. Yes, this doesn't feel good. My body feels overwhelmed. That's just epinephrine. It's doing its job. So let me just push past the sensation and move towards all the benefits of it, which means my vision is sharper. Like my ears are working better. I am stronger than I usually am, right? I'm faster, and just kind of recognizing the benefits of that rather than feeling inhibited by it.
Yeah.
And then just know, like, this is not going to happen tomorrow. You're not going to be like, well, Sarah said, and someone's going to choose. I'm going to choose to not be inhibited. It has taken me several attempts and practicing in like mindset shifts and finally landing on that phrase, it's go time, years into my career. The first couple years was like, oh shit, is what was really happening in my head. But now it's turned into, okay, instead of, oh, this is terrible, it's like, oh, all right, it's time. It's time to do what I've trained to do. It's time to help this patient. And no, you're not going to know it all. I've done this for 21 years. There's still codes I go to and I have no idea what the patient coded. There's times I'm like, I don't even know what to do next. But what I do know is ABCs. I do know how to make sure we are treating the airway. We are doing compressions. We are responding to the patient. I can do those things. You don't have to have it figured out just yet. So I don't have like a holy grail secret sauce. I don't. I have not figured out how to keep my heart from racing in a code. And mine does it every single time. I just learned to kind of run with it and be like, all right, this is what's happening. I know how to like dance alongside my racing heart and my shaky hands. This is just part of it. I'm just going to embrace it and know that it's helping me rather than hindering me.
I love how authentic you are and honest, because even just listening to your background, like, wow, you have probably been in 1,000,001 codes. And to hear that you still have that reaction of, getting nervous and having your heart racing and sometimes not knowing what is best for the patient or next to do for the patient is reassuring, because, no one's going to be perfect. This is scary for almost everyone. But at the same time, being able to notice your body go into that instinctual response of that emergency, like anxious energy, and being able to be like, okay, wait, now it's go time. And now I'm going to take some action. And like being able to almost put a spin off of it where you make it more of a positive energy versus frozen and almost paralyzed, with fear. So I really appreciate you sharing that. I love the idea of picking either a mantra or a saying or a phrase that just helps you recognize what you're in and switching the gears on so that it can be a little bit more confident and action taking versus frozen. So that's such good advice. I've never heard that before. So I really, really appreciate that. Now, would you say, if you were to tell like a new nurse, if they came up to you and said, Sarah, do you have any advice for me for code situation? If you had to give one piece of advice to a new nurse, what do you think that piece of advice would be?
I don't have one. I think it's going to be a couple.
Okay.
I think you need to be aware of how to respond to emergencies in your environment. You have to know where the code card is. You have to know how to call a code blue. You have to know how to use the BVM so you feel comfortable actually using the equipment. That's thing number one. Thing number two, do not wait until you know all the answers or till you know what's wrong or till you know you're not going to know. Just be okay with flying by the seat of your pants and using what you do know, which is basic like BLS, right? You do know that. Just start with that. It is a team effort, this whole saving lives thing. And so just know the team will come alongside you and together you'll figure out what's wrong. Just start with what you know. And then thirdly, I would say breathe through it. Just make sure that you're doing just don't run away. Don't run away. Stay with it. Like it's uncomfortable. Just stay. And like practice is not make perfect. Practice makes proficient. second. And so the more you face this uncomfortableness, you will become more proficient. And maybe one day be able to teach someone else how to do it as well. But yeah, just don't run away from it. This is part of nursing. Just keep facing it, knowing that you're going to do the best of what you got.
So true. I feel like that is how we learn the best, whether we want to acknowledge that or not. Being in those scary situations and doing things that we're not comfortable with, that is literally when we grow. So don't run from it if you can. Stay there, take it all in. Even if it's a code on your unit that maybe isn't your patient, if you can step away from your assignment to just witness it or be part of that energy, the more we expose ourselves to those things, the more we'll have confidence the next time around, right?
Sure.
And gain some perspective. Now, I want to just, before I ask you some closing questions, I just want to touch on, let's say you have a rapid response or a code that goes poorly and your patient, maybe they pass away or something, it doesn't go the way that you obviously as a nurse would hope for it to go. How do you recommend nurses, especially new nurses, now getting into the trauma side of our job, how do you recommend they come back from that or work through that? I know some hospitals, they have some debriefing protocols. I have never heard of any that are super successful, to be completely transparent with you. Is there anything, any like tips or hacks or resources that you recommend for nurses that maybe they had a code and it's with them? It's sitting on their chest, it's in their head. How do they work through that?
Okay. So I'll start by saying, usually the question I get asked is, how do you separate work from home? Or how do you, what's the word we'll use? Like disconnect, or how do you
compartmentalize?
Like compartmentalize professional boundaries. The answer is I don't do that. I don't have a good solution, because I've never been able to do that. Stuff sits with me for a very long time. I could still walk you through the first code I responded to. Like I still feel all of those things.
Yeah.
So I think, at least for me, the way that I'm wired, the reason that I'm still able to show up healthy and whole for these patients 21 years into this chaotic nursing career I have been a part of, respond to emergencies literally the entire time I've been a nurse, the way I'm able to do it is I take time to face those hard emotions rather than just like, all right, push it down, move on. I got more patients to care for. I can't face that. That was too heavy. That was too hard. I don't want to think about it, rather than like scrolling on my phone or binging Netflix or, other more unhealthy habits. I don't do any of that. I sit with the sadness. I sit with the trauma. I face it. So like, I love music. I love podcasts. On my way to work, I am like singing, windows down, learning new things on the podcast. On the drive home, silence every time. And it's not because I don't like music or appreciate it. I just know I just faced 12 hours of hard stuff, right? Shared space with people who are grieving, people who are scared, people who are anxious. All that affects you. I saw tragedy. I saw people die. I saw people get bad news. I need to process that. And so I do. I take time to face it, to like come to terms with it, to feel all the feels. It's okay to cry yourself home. It's okay. Like, it sounds like, oh my gosh, why would you want a career like that when you cry at work or on your way home? Because there's also so much beauty behind the work that we get to do. Like, yeah, it's hard. I didn't become a nurse because I wanted an easy job. I became a nurse because I wanted a job that impacts people. Man, we get the opportunity to do as nurses. And so whatever that means for you to face the hard stuff, maybe it's a silent drive home where you process the terrible stuff you saw on your shift, where you process the interactions you had with patients, with coworkers. Maybe it's getting a therapist that you can process that stuff with. Maybe it's a safe friend who maybe also works in healthcare that totally gets it. Maybe it's your spouse. Like, have people that you can process the hard stuff, because if you just keep pushing it down, it will explode in your face. And I have seen so many amazing nurses with huge hearts, with so much compassion, leave the bedside. And it's not because they couldn't do it. It's not because they weren't resilient enough, because they weren't good enough nurses. No, they were amazing nurses. Some of the best ones I've known have left nursing altogether. And it's because I think they didn't take time to process that stuff. It was like, and I know with COVID, it was hard to make time for that, right? We were just like emergency after emergency, like sick after sick. There wasn't time and space to process. And maybe that's a part of it. But I would definitely recommend finding a way to process whatever that means for you. Taking time in prayer, taking time to journal. I do all of the above, and I do face the hard stuff, but I also feel all of it. I still, there's certain patients where like certain last names that if I hear that, I'm like, oh yeah, I remember that precious patient I cared for and we lost him. I still feel that. I'm not broken. I still am an awesome nurse. I just got a big old heart. And so like, does that get in the way? Maybe. But I think that I've chosen, like, there have been times where I have cried through the compressions. I have like cried through the documentation, but I love this work we get to do so much. I love that we get to care for people on the worst day of their life. We get to hold their hand through a really scary event, and it's heavy, right? Like, I'm even thinking about it. Like, the impact we get to make as nurses, like, it's heavy stuff, but I wouldn't want to do anything anything else. Like, I don't want a boring job. I don't want a job that is easy. I mean, sometimes I do. Sometimes I'm just tired. Overall, when I think about the trajectory of my life and the impact I want to make, I want to be there for the hard stuff. And so if that means I have to take time to do self-care and invest in myself so that I can show up healthy and whole, I'm going to do that, right? I think too, like, you have this idea that it's just a job, right? You could stay up late and have 4 hours of sleep and hop into your nursing shift. Oh, no, you can't. This is not Chick-fil-A, right? You're not just serving chicken. You are caring for big human souls. You know, like, you're caring for these, like, humanity. And so I think it is important to take time to, like, get a good night's rest, pack a healthy lunch, you know, like, take your lunch break, take time to pee, do things that fill your cup and give you life, because you have to have a full cup. You are just be pouring out for 12 hours. And if you show up empty, well, you're running the tank on empty. And so I think the very long answer to your short question is the way that I continue to respond to emergencies is I have taken time outside of the hospital to care for myself, to process the hard stuff, to fill my cup so I can keep showing up for the patients.
Yes. Everything you're saying, like, I got teary-eyed and choked up. I had chills. I think a big piece of advice that I really appreciate from you is to not fall into those distractions to ignore our pain. And I think in today's world, it's really hard. We can get in the car and put on a podcast and be in a whole nother world and, you know, in our head. We can scroll social media. You know, there's always a way to distract ourselves, but that is just a Band-Aid. That is not going to help you move on and heal from what you just witnessed or were a part of. And it's a really tough job. And I also, when I started in 2012 as a nurse, they were here and there starting to talk about self-care, but it was looking more like getting a massage, going to the spa. It wasn't these little things like maybe just telling yourself, I'm not going to pick up an extra shift this month. That's self-care. Or reading a book, or going for a walk, or just like you said, sitting with your emotions, journaling. Like, it, to me, I always thought, oh, wow, it has, like, self-care is so expensive. I can't go to the spa, you know, I need to make money. But actually being able to take some time to recognize where you need some love and time and healing and rest and recharge. It can be free. It can be whatever you want it to look like. But that is how you continue on in this job, in my opinion. It really is a marathon. It's not a sprint. So you have to be checking in with yourself so frequently. And I wish that I had done that when I first started.
All these lessons I'm sharing with you, this is advice I wish I would have taken when I was 20 years old. Yeah, but no one told me this stuff. Or if they did, I was too dumb to listen to it. I don't remember. But now I know, okay, no, this nursing job, if I want to stay in this, like, for my whole career, I'm going to have to implement some strategies to show up whole, because this will drain the life out of you. This is heavy work that we do.
Amen.
It's also so rewarding. So
So
rewarding.
true.
Real quick side quest. I know this is not, you want to talk about emergencies, but we're talking about resiliency. Okay, real quick. The other thing too, because most nurses tend to be very driven to help others. Like, a good day for us is we got to help someone else. And so we aren't the ones who are like, yeah, I'll pick up extra. Yeah, I can help out. We say yes to so many things and maybe we actually don't want to do it. We just feel like we should, or we, I don't know. I think a lot of us are just wired that way. And that's a good thing to have, but it can also really harm you. It's harmed me a lot over the years. And so I would say when making your schedule for the month, yes, you have your work schedule, but go ahead and schedule in some of those things that fill your cup. You know, like, okay, I'm going to do yoga on Thursday because I'm off. I'm going to take that trip with my friend. We're going to go camping. I'm going to make sure I have, you know, board game night with my neighbors, like whatever it is, fill in the things that fill your cup. I actually have a list of things that fill my cup, because sometimes you forget, oh yeah, I do have hobbies. Oh yeah, there are things that, like, I really love doing. So I have this list and I will, like, throw it into my calendar so that I make sure I make time for those things. Otherwise, on a day off, you're like, oh, what am I going to do? I guess I'll pick up or binge TV and do absolutely nothing. Or you can do the thing that you know is actually life-giving, going and finding a hammock and sitting in the sun, or, you know, taking a walk in the nature. Or for me, it's snuggling babies. All my kids are bigger now, but I love babies. And so, like, which friends have babies that I can go, like, snuggle a baby? Like, there's things that I know give me so much life and so much joy. How can I squeeze those into my life so that the crazy 12 hours of high stress and high task overload, I can balance that with baby snuggling and being in a hammock and dancing with my kids and swimming in the pool and, like, things that give me life. Throwing those in there as well. If you don't schedule them, they will not happen. You will just be too tired after your shift and you will binge and do nothing. So schedule them.
I totally love that, because I think most of us will not call out of work unless, like, our arm is ripped off our body or something really traumatic has happened to us or our loved one. But yet if we think we're going to do these things for ourselves, we're also the first to like cancel it. Like, it's like, okay, I'm going to do some self-care. Oh, never mind. No, I'm not. Like, and I'm like, wow, we would go to work, put work so high on our priority list, but we should also be putting these self-care things on our priority list as well. And not just easily like overlook them or book us to do something else instead. Like, they should be at that same priority level as work so that we can keep showing up for our patients and delivering the best care possible. So it's so interesting. I could go on a whole tangent about that. We'll have to do another episode on just how to survive in this profession. But I wanted to quickly, if you don't mind, sharing some of your services and educational tools that I believe you have offered to anyone out there. Just if they're like, ooh, I learned so much from Sarah in this one episode, I would love to see what else she has to offer. Could you share some of those things with us?
Sure. Well, I have a podcast with 139 free episodes, so definitely check that out because it's free. I spent so many hours, labor of love, so please let it help you in your career. It's called Rapid Response RN. And then I have a 1-hour mini course. I think it's great for a new nurse especially. It's called Rapid Response and Rescue. So it's 1 hour, it's 1C. It's basically a framework for how I approach emergencies. A lot of stuff we talked about today, but some additional things, some behind why patients look the way they do when they're crashing. So take that course. I think it's helpful. And then I have this thing called Rapid Response Academy, and it is for any acute care nurse. So ER, ICU, med surg, anywhere where you're taking care of patients who are acutely ill. So maybe if you work in a clinic, that's great. But I think these are mostly for patients that could most likely crash on your shift. So Rapid Response Academy is like a monthly membership, and you get to, every Friday I teach live. I support these nurses through like mentoring and coaching. They support each other. It's a great community. So it's podcast 2.0. Like the podcast is just me and your earbuds. Rapid Response Academy is like me and your face. We're meeting on a weekly basis. You're getting support from other nurses. And for me, it's just a great community. I put a lot of time and energy into Rapid Response Academy. I have just fallen in love with the nurses that are part of it. We are taking a break for the summer just because I have so much time with my family, but it'll be starting again with the fall cohort. So if you're like, oh my gosh, I would love to have like extra coaching, mentorship, training for pathophys, Rapid Response Academy is a ton of fun. And especially if you're new, it's just a great community of nurses that are all trying to be excellent together.
I love that. Now, before I ask you our last question, where can everyone find you, Sarah?
I am the Rapid Response RN on all platforms. So Instagram is where I'm most active. I think everything I post on Instagram automatically goes to Facebook, but I never look at it. So if you want to message me on Instagram, not on Facebook. On YouTube, I do have a TikTok that I haven't posted on in 2 years, but it does exist. So Instagram is the best way to find me, honestly. And it's the Rapid Response RN.
Now, last question for you. If you could go back to the new grad nurse Sarah, I think you said you were 19 years old when you first started, and if you could give that sweet Sarah one piece of advice or maybe tell her one thing about nursing in general or her future career, what would it be?
Okay. This will narrow down to one thing I can, but I can do two. Thing number one is they don't all have to like you, Sarah. I think I had this idea that I was going to like fix everybody, like bond with all the patients. The doctors were going to love me because I was so helpful. That was absolutely not true. So when you're doing the right thing, sometimes people don't like you, and that's okay. That's thing number one. Thing number two is trust your intuition. I think the biggest lesson of my first year was I would have these like feelings that something's wrong with the patient. They're getting sicker, like we're missing something. I had that feeling. I'd be like, the vital signs are fine, but the doctor says it's fine. And I just like kind of learned to write that off. I thought that I should be writing it off because the vital signs aren't proving that feeling I have. But my first year of nursing, I saw time after time, I didn't know what was wrong. I didn't know why they were declining, but I knew something was up. I learned, oh, that feeling, I should trust that. I should follow that. I should investigate that further. Just because the vital signs don't prove that feeling, I'm going to keep looking. I'm going to keep assessing. I'm going to keep reassessing to figure out what's wrong with my patient. I'm going to keep using my voice to speak. And so that's the two-part lesson. They actually go hand in hand because sometimes I would be afraid to use my voice to speak or advocate because what if I look stupid? And now they don't like work with me because I feel like I'm like crying wolf all the time. I don't even care at this point. I'm like, my job is to do what's right by my patient. If Dr. Bubble thinks I'm annoying, that's fine. That's their business. I'm doing what I'm called to do, which is to advocate for this person. So if you think that's annoying, if you think you don't like work with me, I'm sorry for you. But I just serve for the patient. And then just to trust that intuition, because I tell you, so often it's been spot on. I didn't know what was happening, I knew something was, and I was correct. So if you are new listening, they don't have to like you, and learn to trust your intuition.
Wow, Sarah. Oh my gosh. Thank you so much for your time today. So many of us go into nursing with the goal of helping people and saving lives. And I feel like the knowledge that you shared brings new nurses one step closer to just that. So thank you for being being such a light in the profession and for the incredible work that you do to empower and educate other nurses. I appreciate you so much.
Thank you so much. It's a pleasure to chat with you. Thank you.
All right, friends, that's a wrap on today's episode with the incredible Sarah Lorenzini, the Rapid Response RN. I hope you're leaving this conversation feeling more confident because Sarah shared so many practical, real-world insights. From her motto, call early and call often, to the power of engaging your nursing intuition early in your career, this episode was all about trusting yourself and taking action. She reminded us that you don't have to know why your patient is declining. Your job is simply to recognize that something's off and to communicate that early. We also cover how to paint a strong clinical picture when reporting changes, how to stay calm in the chaos of a code, and how to use a simple, grounding phrase to move from fear and into action. Truly, so many takeaways in such a short time of this episode. If this episode resonated with you, please take a moment to rate and review the show. It helps so much. And if you know a friend, coworker, or classmate who could use this episode in their life, send it to them and let's keep lifting each other up. And as always, I have one hand for me and the other for you. Signing off. Well, that's it for today's episode of Life After Nursing School. I hope you feel more confident and ready to tackle the challenges that come with starting your nursing career. Remember, the first year or two might not be easy, but with the right mindset, you can overcome anything. If you found value in today's episode, I'd love for you to hit that subscribe button so you never miss a future episode. Also, please consider leaving a review on your favorite podcast platform. It helps so much in reaching other new nurses like you. Thanks for listening, and remember, you've got this. Take care and see you next time.